And now please welcome to the stage DARPA clinical geneticist Dan Wattendorf.
This is 1918. A transmissible infectious illness crossed the globe. It infected 1 in 3 people, and 5% of the population of the globe succumbed to this illness. We did not have vaccine for it, and it was influenza. Now fast forward into 2009, when we now have vaccine, and let's see if we did it differently. I'm about to show you actual data in cases in millions over days as the year's events occurred while this disease transmitted in the United States. It was a similar strain to the strain of H1N1 that occurred in 1918. And let's see how we did with our best vaccine technology. What we did was we isolated strains of the vaccine. We took those strains, we put them through a process of identifying the appropriate proteins and growing them in eggs, isolating those proteins, and then we injected them back into the human body. The proteins of the flu that we grew outside of the body led to a series of cellular immune signaling and processes that in some people, 40 to 60% in fact, would ultimately be protected through the development of antibodies. Now, what we can see from the data at the top of the slide is by the time we had completed this process, shipped the vaccine, put it into people's arms, and allowed the process in their body to generate that immune response, and having only 40 to 60% effective, we achieved averting 1.6% of the 60+ million cases in the United States. If this was as virulent and lethal as the 1918 flu, millions of people would have died, and this was the fastest vaccine ever produced. So vaccines are not always an effective process to halt the outbreak of a rapidly transmittable infectious disease, and even for one which we know how to make a vaccine for. Now, if we want to make antibodies, we could potentially look at the solution of finding individuals that have antibodies, because antibodies are ultimately what we are trying to achieve with vaccines. Well, we saw an example of this in 2014. This happens to be Dr. Ken Brantley. And there's 2 methods right now that we can use with antibodies to protect an individual of infectious illness. With Ken Brantley, he came to the United States, to Emory Hospital. He recovered from Ebola, and his body, just like in a vaccine process, generated protective antibodies in a slew of other antibodies. Not knowing which ones were protective, he went around the country giving his blood 1-to-1 to other patients and cases that were affected with Ebola, hopefully helping them. Unfortunately, that's not scalable. We don't always have one person for everybody who is exposed to an infectious disease. So we have another technology that began 20+ years ago, which is the field of biologics. In this area, we try to identify the correct antibody from an individual, and then we make it in a bioreactor and scale it to the population. And often we use an IV administration for this. But there's an Achilles heel too, because that is a 9-month production process using our best pharmaceutical companies in the world. If that's a 9-month process and we just saw vaccines with 6 months, this is not a solvable solution. So if we could have the speed that we see on the one side of the slide with the scalability that we saw on the other side of the slide, and the ability to distribute it to the population immediately, not requiring an intravenous administration, we might have a solution that could allow us to solve an effective outbreak against an outbreak in time. And this is what we aim to do. So we look back again at the influenza chart that we looked at before, and let's see how we could do it differently. In this case, what we would do is, from the circulating strains, What we are allowed to do now is identify special antibodies, because of the speed of discovery of these antibodies, that not only bind to the tips of the virus that change and mutate every year and in time, but looking at antibodies that bind to common regions and identify those, giving us a base antibody that is protective against most strains. But of course, evolution is very challenging, and these viruses are constantly mutating, and we potentially can find antibodies that are ineffective against all these strains, and we may have a new outbreak. Again, because of this speed of discovery, we could add that new antibody to this cocktail, but we still need to make it. If we make it inside the human body, we can abbreviate this production process, and we would make it inside the human body, not by providing the protein, the antibody, but providing the genetic sequence for that antibody with a synthetic process. The body becomes the bioreactor. And we have done this. We've done this for flu, and we're doing it with the Ebola patients that survived in the United States. And in fact, what we have seen, particularly with flu, is that we've seen over 1,000-fold more potent antibodies than have ever been reported, in laboratory settings, of course. Separately, we're able to show that when we give these genes for these antibodies in a format that doesn't stay in your body permanently, we can still provide a production platform that gives you months of protection. Coupling duration with drug concentration and the immediate production of antibodies, hopefully together we'll be able to stop future outbreaks early in their course. Thank you very much.